Everyone's doing well. Hi, Laurie.
Hi.
Thanks for joining us. Welcome. Thanks again, PMD Alliance, for hosting. And it's a pleasure to have Dr. Mischley join us today. She's a good friend and close colleague, and we've had the pleasure of presenting in various venues, be it in the movement disorder world with neurologists and blue blazers and suits, and also in integrative medicine worlds where people are a little less stuffy and more fun, and we get to go on fun boat rides together and other things in that world as well. So it's always fun to mix it up and have Laurie on. She's a really popular guest on this series before. I think she and I did a video a few months ago, and it's had maybe like, I think 1,500 views or something like that. It's sort of been the most popular of all time videos of the PMD Alliance series on YouTube. So happy to have her on, and always fun to kind of wing it a little bit. We have a few topics, and I was like, Laurie, do you want to do slides? Do you want me to come up with very set questions? And even she's like, no, just ask away. Let's come up with topics. So so we will take some questions from the audience as well. But one of the things I wanted to have Laurie be able to speak about, and first of all, I'll tell you a little bit about her, and she can expand on some of her recent passions, and maybe it'll get our juices flowing with questions a little bit. But Laurie is a naturopath. She works up in Seattle. She's working both at Bastyr, and her main affiliation these days is at the University of Washington, where she's affiliated with the radiology department. She does a lot of interesting trials, both in an interesting survey type trial where we'll be talking about patient-centered outcomes a little bit. She's also done some imaging work. She's spent probably the last 20 years, I think, has been her passion to take care of Parkinson's patients, just as I have, but with sometimes a different lens, and has written a book about Parkinson's disease patients and their treatment, and is just a really out-of-the-box thinker, which we've been trying to strike up a little bit of out-of-the-box conversations on this series. So I'm happy to have Laurie join us today. Laurie, do you want to add anything about your extensive background? She has a PhD. She's got like a million sort of degrees. It seems like every time I turn around, she's getting another degree. So tell us a little bit about yourself.
Yeah, thanks. No, the only thing I'll tweak a little bit in there is the first 10 years I did general neurology, and in 2010 is when I closed my practice to everybody except people with Parkinsonism. So it's only been 10 years that I've been purely focused on Parkinsonism. And even though my PhD is in nutritional sciences, my undergrad work is nutritional sciences, what nutrition and what the human body needs in order to be healthy and thrive has really evolved over the years. And so as I'm learning more and more about what do people with Parkinson's need to be healthy, and do they have unique nutritional requirements? Nutrition doesn't always come in food. And so my quest to try and figure out how to get people with Parkinson's what they need has really evolved past the idea of, vitamin D and fiber into things like social health and financial stability and, community. So yeah, no, I think that's a nice summary to dive in.
All right, well, why don't you tell us a little bit about what our main topic is going to be, which is patient-centered outcomes. Can you maybe frame that in how research is usually done and what kind of outcomes is usually out there, and then why we've been passionate, you and I, about focusing maybe a little bit differently on what matters to patients and the patient-centered outcomes.
Yeah, great. So yeah, one of my favorite topics. So in 2010, your tax dollars, I got an NIH government grant to leave practice and go into research. And I had a 5-year job. My job assignment was to find better ways to study Parkinson's disease, especially as it related to complementary and integrative medicine. So the idea was kind of, we have historical use of, say, mucuna or ginkgo or something like that. And then when conventionally trained researchers try to study these plants, they take out the Alzheimer's drug, they plug in the ginkgo, they weren't getting the results that were anticipated. And so the thinking was either these plants, these medicines that have been historically used aren't really working, or the way that we are studying them isn't right. Ginkgo was never used in a pill form by itself. It was used in combination with other herbs. It was personalized. It was done in conjunction with exercise, with other things. And so my assignment was to find better ways to do complementary and alternative medicine research on Parkinson's, legitimate research, but study things like personalized medicine. So in a traditional study, what we do is we pretend that both groups are exactly the same, except one group gets the red pill, one group gets the blue pill. But for all practical purposes, we try and recruit people who are otherwise identical. And you all know that's not possible. When we translate that to the real world, there are so many hundreds of thousands of differences that it is virtually impossible to isolate red pill from blue pill. And so the double-blind placebo-controlled trial isn't working in a disease as diverse as Parkinson's disease. And the other problem that we have, everyone wants a disease that slows, a therapy that slows progression. The other problem that we have is that this is a really, really slowly progressing disease. So even if we give one group the red pill and one group the blue pill, that means we need to enroll 1,000+ people and follow them for 18 months plus to be able to see, can we tease out a difference in spite of all the background noise of diversity? And we have now done, I think, 19 of these phase 3 efficacy trials, double-blind, placebo-controlled, multi-center efficacy trials, and every one of them has come up as a ineffective, or the therapy isn't working. And so it might be that we keep getting it wrong, or it might be that the way we're doing the studies is wrong. And so what I started doing is looking at, how are we measuring progression? How are we measuring Parkinson's disease outcomes? And so historically, there have been kind of two big ones that we use. It's the Hoehn-Yahr, and that one's very slow to change. One-sided symptoms, two-sided symptoms with balance. It can take years to go from a 1 to a 2 or a 2 to a 3. So that is kind of useless in terms of studies. We can't follow you long enough to watch to see how many people move from a 2 to a 3. And so what we end up using most often is something called the UPDRS, the Unified Parkinson's Disease Rating Scale, which is much, much, much better. It changes much faster. However, it fluctuates over the course of a day. The score you get when you wake up unmedicated is different than when you're peaking, is different than right after you ate. And so this is a 5-minute snapshot that your neurologist gets over the course of a day, but it doesn't necessarily do a great job reflecting you. It doesn't even ask about constipation. It doesn't ask about a lot of things that are really affecting patients. So what I did was I stepped back and I said, how could we build a rating scale that would truly reflect the patient experience, which is what the FDA is asking for anyway. They want more medicines that improve your experience. So how can we create an outcome measure that when the scale changes, patients say, I feel better? And so I started with my clinical experience and some review articles, and I made a list of about 25 symptoms that were very common in Parkinson's disease. And I solicited feedback from my patients, and they reminded me that I had left a couple out, and so we added a few more here and there. But what we did is we came up with a list of 33 symptoms, and we put them all in a slider bar. And so we asked people on average over the last 7 days, how often or how severe would you say this symptom is? And so if it's not, can I share my screen and show people what it looks like here? Yeah. So what this is it looks like this. You go to propd.org and we ask you, on average over the last week, how often, how severe has your slowness been? And you can say, maybe a 1 out of 10, about there. Constipation, no problem at all. Walking's been a little difficult, no problem with freezing, no problem with falling, but so you can kind of estimate how severe any of your symptoms have been over the last week, all averaged out to the best of your ability. And then what happens is you get a total score, and the lower is the better. And what we've done is we've correlated this with other symptoms of disease, other scales and quality of life. And what we've seen is that when every one of these green dots is a real person with Parkinson's. We've got 2,200 people now in the data set. The average person is diagnosed around 580 and gets worse at about 38 points per year. And so what this allows us to do is, I'd say the most important thing here is that everyone can agree. The lower your score, the happier patients, researchers, and providers are. So if you go through and everything on this list is healthy, 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 I don't have that, your score is a 0 and everyone's happy. So that was kind of how we came up with the scale. And we have now published in NPJ, this is a journal publication showing that the scale correlates very nicely with other measures of disease severity. And that is kind of the beginning of this patient-reported outcome measure. So I'm really passionate about, I kind of joke, not very funny, but we have for the last 200 years defined Parkinson's disease by the symptoms that the provider can observe. But, we define it by what we can see in the clinic. And when we survey people with Parkinson's, you describe pain and fatigue and constipation and sleep problems that I can't see in the clinic. And so what I'm really passionate about is shifting from a provider-centered definition of disease to a patient-centered definition of disease, but one that is quantifiable and researchers and physicians can also use.
That sounds great. Yeah, I mean, I think it's such a complex disease in each person, and also, it shifts from day to day, year to year, and it's also, one of the issues is that there's such a non-motor component that we really have spent so much time quantifying the motor aspects of things, but when we talk to patients about what really bothers them on a day-to-day basis, it's really these non-motor issues, and even the scales for non-motor become hard to sometimes define, because when we're talking about things like cognition or depression or apathy, sometimes these scales in a Parkinson's population are very different than, let's say, in a geriatrics population, or when we're looking at psychiatric scales such as schizophrenia, for example, we're looking at psychosis scales that were defined for other patient populations. So it's really important to think about these things, and I think that the work that you're doing is really important. It's just been sometimes hard to sometimes get a sense, for people who are used to that standard trial approach, how to think outside that box. And I think part of what we're trying to do is get people to understand why thinking outside these boxes is important. So very, very important. So tell me a little bit about the CAM-PD study and how people can enroll, and how many people you have in it at this point and things like that.
Yeah, so the ProPD rating scale was essentially built to serve our needs in the CAM-CARE study. So what I saw happening in the field was a whole bunch of time and money and research going into questions to find answers that patients weren't necessarily asking. Patients wanted to know, how do I not fall? What should I eat? Doesn't matter what type of exercise I do. And most of the research that I saw happening was into some molecular mechanisms of disease. How do we stop alpha-synuclein from aggregating, that kind of stuff. And so that's where I learned the word pragmatic. Pragmatic research is research that as soon as the study is over, we have an answer that physicians and patients can immediately put to use. It's not just a little piece of a larger puzzle that may someday contribute to a larger body of knowledge. This one study by itself delivers usable information as the study gets completed. And so I personally am really passionate about pragmatic research. I want to spend my days answering the questions that patients have. And so what I did, because I had no money, no funding, this was all kind of just my curiosity, I realized that it was really inexpensive to design a survey and just ask patients out there, who are you, how are you, and what are you doing? And then I could write the code that would tell me who are the people who aren't progressing and what are they doing differently? Who are the people who are fast progressing and what are they doing differently? And so that became the CAM-CARE study. We have now recruited over 2,200 people from a bunch of countries all over the world, 1,600 of which have idiopathic Parkinson's disease. And we are beginning to, we're about 6 years into the study, and we are officially starting to publish a lot of the good information that we're learning. So we have already published on supplements and dietary factors associated with Parkinson's a couple years ago. And then we just published, not in a peer-reviewed journal, but we use the exact same, am I sharing my screen? Here.
Not yet.
We used the exact same analysis that we had previously used to come up with this website here. So this website is livinghealthywithparkinsons.com. Any one of you can go to it. We designed it so that you can learn, just like if you were reading a paper, you could read our statistical methods, how we did what we did, why we did what we did, who's responsible for the data analysis. But this is what the site looks like. And these infographics are all available for you to download. You can print them out, you can hang them on your refrigerator, you can share them with your other practitioners, your support group, but they're designed to be one-page synopsi of what we are working on. And so I think Indu and I will probably get into some of the social health stuff in a minute, but
yeah, why don't we look at, maybe let's start, let's look at food maybe first.
So, you know, this is just, and again, we talked a little bit about this in the previous one, so I'm not going to spend a ton of time on this, but I just want to show, of the 1,600 people that we surveyed, what we did is we asked, are there any foods that we see different between the fast and the slow progressors among the rate of people's progression? And so the analogy that I use with my patients is, imagine that you are in a car that's in neutral, going down this very slow, steady decline. You're just slowly drifting downhill. And so if I were to help you interpret these data, I would say, imagine that the things in red, anything in red is like putting your foot on the gas pedal, and you're kind of accelerating your rate of degeneration. And then anytime you eat some of the stuff in green or engage in the behaviors in green, that's actually kind of like throwing the car in reverse. And so we can actually see that some people are doing better over time depending on some of their lifestyle habits. And so we can't tell you why. We can just tell you that the people who eat the foods in green are reporting fewer symptoms over time, and the people who consume the most, and it's dose dependent, the most stuff in red are reporting more symptoms over time.
So for some of the, there's some people on the phone, Laurie, so maybe we could just shout out a few of the things that are green and some that are red, maybe as
Sure.
the bigger kind of.
So I'll start with dietary behaviors, because it's not all food. I think we really are so focused on what to eat that sometimes we forget how to eat. And so the behaviors that are associated with the best outcomes over time are people who cook most of their own foods and cook for others. They avoid artificial sweeteners, artificial colors, and artificial flavors. They try to eat organically grown foods when possible, and they try and buy locally, like co-ops and farmers markets and things like that. And again, it may not be that the co-ops have anything special, but the type of person who shops at co-ops is getting better outcomes. And so that's what we need to try and figure out is what's going on here. But we can see differences in outcomes among these groups. People who have trouble affording groceries and healthy food have much faster accumulation of symptoms. And so we see this over and over in not just Parkinson's research, but many, many fields of research where financial insecurity and financial stress really makes things harder on people. In terms of foods that are associated with the slowest rate of progression or the best outcomes over time, the more fresh vegetables, fresh fruit, nuts and seeds, non-fried fish, wine, olive oil, coconut oil, and fresh herbs a person eats, the better their symptoms were over time. Conversely, the more people ate canned fruits, canned vegetables, soda, including diet soda, fried foods, ice cream, beef, pasta, chicken, pork, yogurt, cheese, milk, and frozen vegetables. So it's hard to hear it like that. So in terms of meat, beef, pork, chicken were all associated with worse outcomes. In terms of dairy, milk, cheese, yogurt, and ice cream. Pasta was on the bad list, but bread wasn't. And we don't fully understand what's going on with the pasta and frozen vegetables, but those both made the list. And I don't think anybody is surprised by, you know, the fried foods, ice cream, and the canned foods. Again, all of this data was adjusted for income, but it could be that people eating out of cans are more homebound. It's less expensive to eat out of cans. I mean, there could be other things that are coming into play here.
Laurie, can you make the font a bit bigger? I don't know if you, I think you just do it with the zoom, like up at the top. It says, yeah, cool. there's been a request for that. And then also, yeah, so maybe just keep that up there for a second. So yeah, there was a comment about the fact that it basically looks a lot like a Mediterranean diet is what you're recommending and trying to, and I agree. I mean, I think with some of the things that we've talked about, there's confounding variables with if you're not as wealthy, if you don't have access even to food. Some parts, you know, I've been paying a little bit more attention to this as I'm driving around Los Angeles. And we had a dietitian at the VA come on who was talking about, you know, showed beautiful pictures of like yours of all these green salads and things. But then, you know, ultimately a lot of what we had to talk about was what was available maybe at the 99-cent store, because that might have been the only, you know, sort of place to shop, or even the VA canteen or you know, store. So I think, you know, as best as we can, we should try to do these things. We understand that it's not terribly practical. And then some of these things may also have a social aspect to it. So if you're cooking food for other people and sitting down to a meal with other people, presumably after you've made food for them, then that may be a nice thing. And we'll probably get to that in a minute about the social aspects of things. So why don't we, yeah, and people are asking for copies of these slides and graphs. We can try to post a link to that at the end of this. Why don't we look at, since we've talked about the social aspects, why don't we look at the social aspects now, since that's been something that is kind of hot off the press and pretty exciting to both of us.
Yeah. So using the data set that we have, Dr. Subramanian and I and Joshua Farnick have spent the last couple months analyzing the social health data. And this is really, really exciting. The first thing we wanted to do is just ask, is this scale effective at measuring overall health and social satisfaction? And what we could see is, as we expected, the more likely somebody was to say that their social performance and social satisfaction was excellent or very good, those folks had very low pro-PD scores. And as their social health diminished, so did their pro-PD score get worse. So that was a little bit reassuring that the scale was working for our purposes. And then the first thing that we saw here is that just off the bat, we asked people true or false, I am lonely. And you can see that people who are lonely are across the board for the first 10 years of this disease, very consistently reporting that they are more symptomatic. And we don't know from these data which is cause and which is effect. Are they more symptomatic because they're lonely? Does being lonely make them more symptomatic? I mean, there's a lot that we have yet to learn about this, but it's not a little difference. It is a notable difference that people who say I am lonely are experiencing overall worse symptoms across the board, motor and non-motor. You know, and this is something that Indu and I have talked about a lot is, you know, when people hear the word Parkinson's, the first thing they think of is tremor. When patients talk about their stress, they're embarrassed about their tremor. They come in, they want us to hide their tremor. I think it's been really empowering for a lot of my patients to see that when we ask the question about overall quality of life, whether somebody has no tremor, a little tremor, or a severe tremor, that actually has very little impact on their overall quality of life. Where we see huge impact in quality of life is whether or not people have a lot of friends and have loneliness. And so again, this is one of those things where one of our colleagues said that motor symptoms have been a big distraction for Parkinson's disease. Dopamine has been a distraction. Tremor has been a distraction from us really getting to the core of what's going on here. And I think that's a really wise comment. That's exactly what's happened, because it's not tremor that determines progression or quality of life. It is some of these non-motor things that seem to be having the biggest impact on overall quality of life.
Yeah. And just to define, before we go on, Laurie, so loneliness is a subjective feeling. So you feel lonely, but the number of friends you have, you know, is hopefully being reported in a different way that you know, or if you live, we also looked at things like if you live with someone in your home, like as if you're married, if you're in a partnered relationship, if you're single or divorced, we've looked at variables like that. And we can maybe just comment on that outcome as well. But I think, you know, there's sort of, it's hard to measure some of these things. Social isolation is defined using sometimes loneliness, which is a subjective, so that means that you feel it inside, but also using some of these other measures, things that we can actually measure, such as, you know, Are you married? Are you single? You know, who lives in your home? These sorts of things, and then these other outcomes such as how satisfied you are with your relationships. Just because you may be married, if that relationship is not a good relationship, sometimes that may actually also be an outcome measure that is not very accurate. So sometimes the quality of the relationship is also important to sort of factor in when we're talking about these things. But I think it is a little bit mixed in terms of how we can interpret this data. But there's been a couple of comments in the comment section about COVID and how people are feeling more lonely or more socially distanced and alone, or even if they did have loved ones, that they're unable to interact with those people. And I think that is exactly why Laurie and I have been trying to get this data published and get people caring about this in this time frame, is because we do realize that this makes such a big difference for our patients. And we knew, and in general in the aging literature, there's a sense in aging in general that if you are socially isolated, that it is as bad for you as if you smoked every day. And so we already were worried about this. We decided to look into this data set, which Laurie has beautifully put together, asking these specific questions. And we've been able to gather this information and really make this sort of almost a need for a call to action around some of these issues. And then there's also been some information that Laurie will talk about maybe now about scarcity of food and the worry about income and employment and things like that in our populations too, and how that may also impact. And so I think we're really just trying to highlight the fact that it's not just the pills that you're taking or the DBS settings of your deep brain surgery device. It really is taking you as a patient in the context of who you live with, where you live, what your circumstances are in your social situation, of whether you live in a place that you have access to food, whether you have enough money to be able to access, these basic things in life. And actually, these social determinants we're realizing are as basic a necessity as food and water for humans. And so social contact and the ability to be socially connected is as human, a basic human need as shelter, water, and food. And so we're really wanting to emphasize that in our patients and realize that some of you are really hurting right now, which is why this series even exists in the first place. So.
Yeah, and just to really second what Indy just said about the difference between being alone and being lonely, there are people who are in healthy, good, loving relationships and they still don't feel heard or understood. So just because, I'm actually have been really impressed with my patients, the number of people where I will bring up the topic of loneliness, I will share these data with them in clinic. And their knee-jerk reaction is to say, oh, no, I've got a great wife. I'm not lonely at all. No, I've got kids, grandkids all over the place. I'm not lonely. And then they'll come back the next visit and say, I thought about that question more. And I will say, I do feel like most of people in my life who are around me don't understand what I'm going through. They might be there for me in spirit, but I don't feel like somebody really has an understanding of what what it feels like to be this tight, to be up all night, to be tossing and turning. And so I do think there are kind of several layers to asking yourself, how would you answer the question, true or false, to I am lonely? I think it's not, it might change as we develop some more awareness of our lifestyle. And then it's not on this graph, but the only, we looked at all of these lifestyle variables associated with rate of progression, exercise, stress management, meditation, certain diets, things like that. And what I think we were blown away to see is that being lonely or being in one of the bottom two income brackets was worse for you than 7 days a week of exercise is good for you. And that really put it in perspective for us. I mean, I think Indy just said it beautifully when she said, this is a call to action. I don't know that we as practitioners had ever seen ourselves as our job is to help this patient feel a sense of community and financial stability. Like that wasn't something that I learned was an important part of health. and health maintenance when I went through my training. And here I am, if I'm going to just truly listen to the data and let the data speak for itself, what we are learning is that if we don't address a sense of social isolation and financial scarcity of resources, it is going to be virtually impossible to start to appreciate disease reversal, no matter what the medicine is. We really need to address some of these underlying things a little bit more.
There's been a question about the exercise data, Laurie. Is that on here? Maybe we'll just take a look at that.
So what these data say, we asked people about, so we asked on average, how many of the last 7 days a week do you exercise? Have you exercised for at least 30 minutes a day? And over here, this column, you can see which percentage of participants said, 6% said they never exercise, 4% said 1 day a week, 20% of people in the survey said that they are exercising at least 30 minutes a day, 7 days a week. So I think this is not a very typical cohort. I think this cohort is a little bit more active and engaged than we would probably see in the average Parkinson's population. But what it does is it translates to really beautiful data. And this might be some of the first data to show that there's a dose effect with exercise. The more days per week that you exercise, the fewer symptoms people are reporting over time. And I want to point out here that any exercise is good. You notice that all exercise hits the green zone. Anything is better than nothing. But I want to point out that those first 2 days a week don't really make a huge difference in one's overall rate of progression. If you really want to start having a measurable change, reduction in slowing of symptoms, these data would suggest that you have to get at least 3 days a week. And I love my patients who will look at the top two, the 6 versus 7 days a week, and say, hey, I'll take the 292 and I'll go make a new friend. Like, I'm going to take a day off. Right, and so I love that people are starting to play with these data in a way to starting to think about where can I get some points, right? I'm going to go make some friends. I'm going to go eat some vegetables. I'm going to do a couple days a week of exercise and start to like a bank savings account sort of thing. We also saw that people who are overweight are more symptomatic than people who say I am not overweight, but nowhere near as severe as what the difference we saw with loneliness or not. And we also asked people some questions about what type of exercise are they doing. And, this is, first of all, there aren't a lot of people in the database doing some of these exercises. I mean, for instance, rock steady boxing. I every day in clinic, I have a patient that tells me how rock steady boxing has improved their symptoms. And yet these data don't suggest that it is making a huge impact in progression, but I want to make sure that you know that that's not because I don't think it is. It's because not that many people in the study are participating. And so we had the most data and the best data on people who run. So running was clearly associated with pretty impressive outcomes over time. But what I like about this graph are number 2 and number 3, other. Just find something that works for you. I mean, it doesn't matter what it is. Like, it can be rowing, it can be gardening, it can be I got 12,000 steps cleaning my garage yesterday. I mean, it doesn't matter what it is, but find some way to push yourself every day. And then yoga. To me, this just drives home that you do not need to be dripping with sweat and have a heart rate, in the heart rate max target zones to be getting appreciable benefit. So
that sounds good. So there's been a question about the BMI. What was the number of the to say that somebody was overweight?
It was a true false statement. I am overweight. And okay. People who said true are in red, and the people who said false are in blue.
Okay, that sounds good. And then people are asking the level of exercise. So, I mean, we talked about the different types. I don't think you said, did you talk about an intensity? You talked about the amount, right? And how frequently?
Yep. And we have not gotten into intensity, but we are updating this. And there's a new survey going out in the next 2 weeks that we will start measuring exercise intensity to get some of those answers for you.
That sounds good. And again, I mean, I think that, these take-home messages are not to harass you to try to do 7 days a week and eat only salad and, and try to, you know, mint 7,000 new friends tomorrow online or something like that. But I think we're just trying to give you general principles. And if you look at sort of the trend for most of this data, it's kind of what your mom probably told you when you were little is, you know, try to make some friends, try to, you know, eat your fresh fruits and vegetables, try to exercise every day, you know, get good sleep, you know, things like that, that were, you know, don't eat a bunch of junk food and eat alone in your car, you know, McDonald's takeout or something like that. So I think a lot of this is just, you know, general principles around, you know, wellness in general that are resonating probably with aging literature, what we're generally telling people in the public to do just from a healthy lifestyle perspective anyway. The one other thing I will say is that this population of patients that answered the survey, we were looking at that, and it reflects probably a bit younger patients, more women than are commonly having Parkinson's. Parkinson's affects men more frequently than women, but this has been more answered and more participated by women, which in some ways skews the data a little bit, but also is exciting to Laurie and myself because women in Parkinson's have been a really studied and underrepresented population of patients in studies in general. And so I think we're getting to some of the things that matter to this population that she and I both care a lot about and want to advocate for. And so I think it offers a little bit of a different view on things, but certainly we want to expand who's participating in the study. We urge you to, we'll put up some links about how you can participate. And it's how much time does it take and how often are people doing this?
So from the CamCare, so here is the, oh my God, I have too many websites. Hold on one second. Oh, hold on.
That's okay. Don't worry about it.
So it's 60 minutes, about 1 hour every, approximately 1 hour every 6 months.
Okay, which is very, very painless from the comfort of your own home. You don't have to go anywhere or do anything too exciting, right? And all the consents are from your home. You don't have to sign anything in a place. And it was interesting. We had Tanya Samuni come on about studies in general, and she mentioned the word altruism as a reason to participate in studies. And I think that's a really exciting kind of term to use, one that I hadn't really thought about in the universe of this type of work that we do. And so it is one of those things where I think, you know, it's an easy study to feel like you're doing something even from the comfort of your own home. And I know a lot of patients feel like right now, if they were in a study at an institution that was nearby and it's been halted, they're not supposed to be coming in to be examined in person, that they're losing some part of their, you know, altruism experience or volunteerism experience. And so this is an easy way to, you know, get some brownie points from that perspective and participate in something. Someone just asked if they do participate, do they see their own individual results as a score, or how does it work?
Yeah, so the first thing you do, you go to this website and you first look at the informed consent document so you know what you're getting into. And once you've read and downloaded and read that, you can go to this online survey and then you begin. And here's the survey. And so what will happen is right at the bottom of this questionnaire, as soon as you fill out yours, you will get your ProPD score, and you can see how you score compared to other people. If you want your score but don't want to participate in the study, then you can just go to the ProPD, PROPD.org website and ignore the study and just get your score. But you have a couple different ways to get the score.
Great. Okay. Well, Laurie, you're doing a few other interesting initiatives, and I just wanted to highlight a little bit of that and also give you the opportunity to talk about any other call to action that might be necessary. And so I want to give you a minute or two to talk about that. But maybe we could highlight a couple things. One is the Parkinson school thing.
Yeah, so I am trying to make the biggest difference I can in the lives of people with Parkinson's. And one of the reasons I got into research was I felt like one person at a time, while awesome and intimate and effective, I wasn't doing as much as I could. And so I've really gone into research and gone into some of these other directions to try and reach more people at scale. The book writing's good, but it's hard to keep it updated, and not everybody reads well. Sometimes it's hard to have the focus and the visual capacity to read. And so I wanted a way that was a little more user-friendly to teach people what I know. And I certainly don't think that I have any answers that other people don't have, but I think that a lot of people see this disease differently. And so we started this thing called Online Parkinson's Disease School. And what it is it's the same stuff that I say over and over and over in my clinic. And you know, it's not fair to patients who want to learn some of this stuff, but they can't get in for 4 months, and it's beyond their price point or something like that. And so what we did was we put together this 24 course series, and it's the exact same stuff, the conversations I have with my patients over and over. And twice a month, on the 14th and 20th of every month, we release a new course. And I will tell you, there are a couple parts of it. One, I think it's making much more well-informed patients. I love that patients are starting to come in and I start to talk about, you know, how to initiate meds, or when to take their melatonin, or to make sure that it's sublingual or something like that. And I love the number of patients who are starting to tell me, you know, save your breath. Like, I watched the video, I got this, right? And so it's honestly freeing up a lot of time in clinic, because patients are coming in with really well-informed, smart questions, because they've already heard the shtick. Now they can kind of personalize it to themselves. And a lot of people, one of my patients after the first course said, I got more out of this 1 hour class than I have the last 3 visits with you in the clinic. And so it's nice, because there just isn't enough time in clinic to say all the things that patients need to hear. I mean, time and money are limitations. And so what we were trying to do is get past those limitations. So it's been fun, it's been great. And I will tell you, I don't think it's just the knowledge. I actually think it is the sense of empowerment and being a part of something. I truly think that anticipating a new class being released every 2 weeks is part of what is happening here. And so there's a community aspect, there's a question and answer period. And I've never done anything like this before. And I'm actually, it's been definitely one of the highlights of this year for me, to kind of try a new way of reaching people.
That sounds good. I think it's important to think outside the box a little bit. I think that old school books are probably a thing of the past in some ways. And, you know, online, we just have a really interesting way to be able to reach people. One of the things that we've been a little worried about is the folks that can't get online for this type of experience, and may either don't have internet connections or can't afford an internet, you know, computer, whatever. And so there are people that are on the phones that are dialing into this. And I just would hope that your series is also possibly available eventually on some sort of other mechanism through you know, some way that other folks can watch it, because I think accessibility has been something that I've really been trying to think about and emphasize, you know, when we're approaching our patients, because as diverse as the disease is, I think our patients are in various parts of the world, and certainly my vets are, you know, in some very remote places. So definitely want to plug that possibility. So in terms of other out-of-the-box advocacy, Laurie, I mean, I think we've had, you know, Boss Blom and Mike Oken talking about advocacy around preventing certain pesticides from being in the environment, trying to advocate around, you know, lobbying for certain changes in healthcare delivery and things like that. If you had, you know, low-hanging fruit, 1 or 2 things that you could really change about how we're able to treat our patients in this day and age, you know, what would they be?
I think that we are not using so much of the data we already have. I mean, you know, when I'm looking at what's happening with COVID right now, and the way that we're trying to come together and organize, and we put somebody who's in charge over here, that's, you know, we don't have kind of a president of Parkinson's. We're all kind of doing our own thing in our own way, right? And so I just imagine if the world were to come together with the goal of, hey, can we make this disease preventable and reversible? I think we would get much faster results I think that we are sitting on solutions that we're not using. And, you know, in terms of the outside the box stuff, you know, let me just show you. So one of the things I've been working on is I have 2 dogs that I have trained to smell Parkinson's disease in people's earwax. They take a Q-tip and they put earwax on it. And just like the dog goes up and down the luggage at the airport, so do my dogs go up and down this track sniffing people's dirty Q-tips and signaling when somebody has Parkinson's. I have a 2-minute video if we want to watch it. But it doesn't, all the scientists want to know, what are the dogs smelling? Right? And the patients are like, I don't care, just tell me, do I already have this disease or not? Because the dog's going to say yes before I start to have motor symptoms. And so I think that we are already starting to see that we have tools that are cheap, that are easy, that allow us to be able to identify somebody really early in the disease. And I'm doing all this work to try and make see if Parkinson's disease, see if we can, the dotted line represents a decrease in slope. But even if we learn that exercise and a certain diet and some supplements and some friends decrease the slope of progression, we still have this problem where we're getting to this disease 10 or 20 years into too late. The disease is already underway. So imagine if we could use dogs or some other test to identify the people who were really early in the disease, and we could intervene there. The dotted line shows you the impact of that same 50% reduction in slope, but what that would look like if we actually got started when this disease got started. And it's like saving for retirement when you're in your teens. If we can just start getting you to put a little bit away really early in the disease, the impact of this little teeny decrease in slope becomes huge over the next 40 or 50 years. So I'm really passionate about early detection, and it's not just the dogs. I think primary care providers need to be watching for arm swings and asking about sleep and constipation and loss of smell and things like that. But there are a whole bunch of things that we aren't doing that we could be doing right now that would help us identify people early. What was the other question about the unorthodox things that are coming?
Yeah, I mean, I was just trying to see if, give you an opportunity to think about, if you were to advocate, think about, call for action, what area or two. I think that's fine. One question I have been asking everybody, and we can come back to, other things. Actually, before we go there, there's been a couple of questions that I wanted to hit from the chat. One is about beans and legumes.
Yep. Neutral. We do ask about them, and they are not associated with slower or faster progression.
Somebody asked about meats like bison and lamb or something, I think.
Yeah. So not in, I don't know that they're even on the survey, but not enough people are eating them that we would be able to measure an association if it were to exist. If I had to make an educated guess, I would say it's just like in the other meat category. If you're going to eat meat, I would love for it to be wild game and not factory farmed stuff. I mean, if you're going to eat meat, certainly that is probably the better option. But my purely academic guess is that the problem has to do with the animal product itself, not the factory farming stuff that's happening. So I might be wrong about that. Time will tell, but that right now is an unknown.
Okay, and before we leave the dogs, somebody wanted to know how accurate they've been.
They are 90,
above 90%.
No, well, it's here are the numbers. They are about 100% sensitive. They never miss a positive, and 73% specific. So they will occasionally say yes to people who don't have a diagnosis of Parkinson's, and we're trying to figure out if the dogs are just looking for a treat and wrong, or if they are actually identifying people who will go on to be diagnosed with Parkinson's down the road.
Okay, and just to clarify the statement that you made about the there's a premotor complex of symptoms. So sometimes people with Parkinson's complain about things like that they fight in their dreams, or their loved one says that they act out their dreams, sometimes 10 to 15 years before they ever get the diagnosis. Their change in the sense of smell, you can actually test that on a smell test, and changes in bowel movement frequency. So there's certain things that people may have that predate their motor symptoms, like before they get stiff or slow or tremor. And then we can maybe predict from that. And so that's what Laurie was speaking about, is maybe we should be asking primary care doctors to be screening this. And there are studies going on around that as we speak as well. So I wanted to ask you, Laurie, about silver linings. I know you've been doing this work with the sort of some of the Parkinson School, and we've also been talking a lot about social isolation and ways you've been working around using technology to do some of your visits with, I think, telehealth and things. Do you see silver linings that may change our ability to care for Parkinson's patients in the future from this COVID timeframe?
Absolutely. I mean, this, when I started this online school, I thought I was filling this huge unmet need. I mean, there were so many people who didn't live in a city like Seattle that didn't have access to integrative medicine and dietary supplement counseling and things like that. And so I thought it was a really novel thing to bring internet services to people with Parkinson's. And now, I've blinked, a couple months has gone by, and there are hundreds of awesome online programs. And so I think that the COVID thing has really catalyzed a huge evolution in what's available for patients. I am actually really excited about the programs. The online school that we're launching later on today is on exercise. And I asked a couple people, Nate Coomer, Claire McLean, a couple people who have online programs, to submit some of their work. And it is mind-blowing to see what kind of resources are now available for people from their own house. And it is focused, personalized Parkinson's care, specific, from really highly trained people, is now inexpensively available in people's living rooms. And so I think we are going to see a lot of really fabulous things sprout up as a result of what we're being forced to do right now.
Okay. I think people want to see the video.
Okay. I just want to show too, like, here is, in terms of technology, this is somebody who's on the exercise video. We are starting to collect cases from the positive deviants, who are the people who were diagnosed with Parkinson's. They changed their diet, they started exercising every day, they do a couple things right. And it is fun to see that you don't need to necessarily have this progressive decline. I mean, we're starting to collect what we call the positive deviants, the outliers, who don't seem to be progressing like everybody else. So let me just go to, okay, here's the video.
Hello and welcome to the Park 9 testing facility. We've spent the past few months training dogs to identify the scent of Parkinson's disease. The purpose of this video is to demonstrate how we have the track set up and to show the viewer how the dogs signal a positive sample when they find it. I've circled the container with the true scent of Parkinson's disease, which I'll show briefly before bringing the dogs out for each of the rounds. In these first couple examples, all the containers are empty except for a single container that has cotton-tipped swabs from the ears of individuals with Parkinson's. This is our 6-month-old Lagotto Romagnolo, Reese. Here comes our 2-year-old Lagotto Romagnolo, Coco. She fails miserably at walking the track, but has no problem identifying the correct sample. In this second video, I'm blinded to the contents of the containers. This round is more difficult for the dogs because there are now multiple samples from Parkinson's patients hidden among samples from healthy controls. There's a lot we don't know. We don't know what it is the dogs are smelling. We don't know if they can distinguish between idiopathic Parkinson's disease and other forms of Parkinsonism. And most importantly, we don't know how early in the disease the dogs can detect the scent. Currently, Parkinson's disease is diagnosed by neurologists 10, 20 years after the disease has already started. A tool that would enable early detection could revolutionize Parkinson's disease diagnosis and management. Our goal is to convert these dogs into the next generation of medical detection devices.
Very cute. I think I recognize your assistant there.
It's child labor.
Maybe you should train my children to do such things. It would be good. Very good. All right. Well, I think that we are almost out of time, unfortunately. And I think, as Laurie, you and I always know and have talked about, we can talk about things for probably hours and 20 hours, maybe, I don't know, endless amounts of things to consider talking about. But lots of good comments here. People like your dog, love the positive deviance work, all these kinds of stuff. So I think people are definitely happy with what they're seeing and more interested in learning about more things. And we'll probably have you on again later this year with all our data and all the cool things we could talk about. But I wanted to give you, people are saying that they have lots of earwax to donate. You might
Great.
be.
Go to the Park 9 website, PARK-9, and put your name there, and we will absolutely reach out to you. That would be fabulous.
Fun. So we'll have a lot of, you guys are going to have a lot of resources coming your way. We'll link all of this stuff at the end of Laurie's talk today. And I'll just give Laurie maybe a minute or two to talk about what you're excited about. What are the most exciting things in terms of the future of your work, and what are your next, maybe one or two hopes? And then also maybe just close with something kind of a good inspirational goodbye for everyone.
Yeah, no, I truly, truly believe that in the next 5 years, we will start using terms like prevention and reversal for Parkinson's disease. I think that it is so exciting to start to objectively document cases. That scale I just showed you with Terry, who's listening right now, she's logged on, I saw her on here someplace, to see people who aren't progressing, to have more and more role models volunteering themselves to show the world how it's done. Here's how I eat, here's how I exercise. That ProPD, we're working on turning it into an app that people can follow their scores over time and see when they're getting better, see what's getting worse, share it with their providers. I truly believe that we already have access to the resources to detect and find Parkinson's early, to teach people how to change their lifestyle and modify their behaviors in such a way that it slows the rate of Parkinson's progression over time. And I think we really are at the cusp of redefining this entire disease, not by what the physician can see, but what the patient experiences. And so I think I could not be more, and I will say, I truly, truly believe that the first big win in terms of neurodegenerative diseases is going to come in Parkinson's disease. I think it is going to, before Alzheimer's, before some of these other conditions, I think the first big win is going to be in Parkinson's, and it might be easier than we might be able to see truly meaningful results without as much technology and expense is what I think we have been thinking all along.
Very cool. Well, thanks for your passion, Laurie. It comes across in everything that you say and do. Super fun to talk about outside the box approaches. And, I think we need some of you and me to sort of balance out the other folks that don't look exactly like us or think like us. So, but I think it's a multi-pronged approach to just helping solve this disease and help a population of patients that you and I both have grown to love and admire and inspire us every day. So, so we will continue to fight the fight. And thanks everyone for joining us, and thanks PMD Alliance for having us. And I will, look forward to our wave goodbye to everyone, and stay socially connected out there. That's Laurie and my message to you all in COVID, even if it's just picking up the phone and talking to your neighbor, or, maybe standing 6 feet apart from your neighbor over a rose bush and just saying, how are you? And, isn't it a nice day outside? I think, this human connection is so important. And she and I both model this as people who are very sort of, human and socially connected human beings. We definitely talk the talk, and we believe in it. So we want that for you as well. So definitely, get out there and try to connect with each other. So Andrea, I will send it back to you.
Thank you so much. Mic drop. I have nothing to add to that. Amazing. Thank you, Dr. Mischley. Thank you, Dr. Subramanian. This was amazing. We're going to have the recording up by the end of the day. It will have links to the Pro PD rating, so you can rate yourself, to the CAMCARE study, to PD school, the dogs study, and then that Living Healthy with PD and Education is Medicine website. So everything that was on the screen, you will have access to afterwards. I saw some people squinting. You can digest it all, pore over it, contribute at your leisure. So very exciting for that. We have some amazing programs coming up. Rebecca put that link in the chat, so I won't go over those now that we're already 1 minute over. But again, thank you everyone for joining. Thank you to our expert speakers. And now, as always, we'll do our wave off. This is our chance for some long distance eye contact. Yes, we are physically distant, but we're socially together. So great to spend an hour with all of you.
Thank you.